Hello everyone. In this video on obstetric and gynecology, today we are going to talk about gestational trophoblastic disease, and so it is one of the important topic for MBBS final year students. So what is GTD? It is gestational trophoblastic disease encompasses a spectrum of proliferative abnormalities of trophoblast associated with that is associated with pregnancy. It is a spectrum of proliferative abnormalities of trophoblast that is associated with pregnancy. The malignant form of gestational trophoblastic disease is referred as gestational trophoblastic neoplasia. So, talking about classification, the morphological classification of GTD is very less important. So, because at present management is largely medical, irrespective of histology. We don't classify in that way. So for classifying, we can say that gestational GTD are classified as Hydatiform mole. One is complete and partial, that might be complete or partial. Secondly, we have the invasive mole. Thirdly, we have the gestational trophoblastic neoplasia. Fourthly, placental site trophoblastic tumor, and fifth is choriocarcinoma. And talking about Hydatiform mole, and in this video we will be mainly talking about Hydatiform mole. It is also known as vesicular mole. Its type are the complete and incomplete. In partial, it is also known as incomplete mole. So what is Hydatiform mole? Hydatiform mole is the abnormal condition of placenta. It is abnormal condition of placenta where there is a partly degenerative and partly proliferative changes in the young chorionic villi. So there is partly degenerative and partly proliferative changes in young chorionic villi. So that is known as Hydatiform mole, and these result in formation of cluster of small cyst of varying sizes. Because of its superficial resemblance to hydatid cyst, it is named as Hydatiform mole, and it is best regarded as benign neoplasia of the chorion with malignant potential. And talking about incidence, there is wide range of geographical ethnic variation of this condition. The molar pregnancy is common in oriental countries like Philippines, China, Indonesia, Japan, India, Central and Latin America, and Africa. The highest incidence is in Philippines, being 1 in 80 pregnancy, and lowest in the European countries, and USA has the least. And now we will talk about the etiology, how this molar pregnancy occur. The cause is unknown. Cause is definitely not known, but it appears to be related to the ovular defect, as it is sometimes affect one ovum of the twin pregnancy. However, there are various different factors and hypotheses have put forwarded. The prevalence is highest in teenage pregnancy and those women over 35 years of age. Also, prevalence appears to vary with race and ethnic origin, and the faulty nutrition caused by inadequate intake of protein animal fat could partly explain its prevalence in oriental countries like Philippines. And the low dietary intake of carotene is also associated with this molar pregnancy. And the disturbed maternal immune mechanism can also result in molar pregnancy. And talking about cytogenetic abnormalities, in general, the complete mole have the 46XX type of karyotype. The molar pregnancy are derived entirely from father. How? You can see this. This is sperm. There is the empty ovum, and when this sperm gets fertilized with this empty ovum, that is absent, that is empty ovum with no nucleus, or the nucleus might be or the chromosome might be inactivated, and with the empty ovum, and it is fertilized, and the chromosome gets duplicated. The paternal chromosome gets duplicated, and after that result in the 46XX, and this is entirely a paternal chromosome, and it's known as homozygous complete mole, and it is 85 to 90% case. This is the case, and this phenomenon is known as androgenesis, where entire completely paternal derived genetic material is there in the cell, the newly formed zygote. and the chromosome may be 46XX, and this is present in majority, almost 90% of the complete mole. However, in almost around 10 to 15% of the complete mole, the empty ovum might be fertilized by two different sperm, and that may result in 46XX or 46XY type of uh, mole of the zygote, and these both are entirely paternal. The embryo dies early and they cannot be identified in complete mole. So no embryo is formed in complete mole, only the trophoblastic tissue are there. And in the partial mole, what happens is that there is the maternal chromosome is not activated, the nucleus is not empty, but where one ovum is fertilized by two different sperm, and it result in the triploidy condition, the condition known as triploidy, where the cell has three set of chromosome, and there are 69, that is 23 into 3 equal to 69XXX. This is the most common form, or there might be 69XXY. So there may, and rarely, very rarely, 69XYY can be there. This is very rare, and these are triploid and partial mole, and fetal tissue are present in partial mole. That's why it is called partial. And the history of prior Hydatiform mole increases the chance of recurrence. So higher the ratio of paternal maternal chromosome, greater is the chance of molar change. So that is. And we will talk about shortly about the pathology of Hydatiform mole. This is picture of Hydatiform showing the cluster of different vesicles. It is principally a disease of Corian. Hydatiform is principally a disease of Corian. The death of the ovum or failure of the embryo to grow is essential to develop complete or classic Hydatiform mole. The secretion from the hyperplastic cells and transferred substance from the maternal blood accumulate in the stroma of the villi, which are devoid of blood vessel. This result in distension of villi to form small vesicles, and this distension may also be due to edema and liquefaction of stroma. So there is result in distension of villi to form vesicle. We can see that this is a vesicle, different type of vesicle, that's shown by arrow, and the vesicle fluid is interstitial fluid, and it is almost similar to ascitic or edema fluid, and the vesicle is very rich in HCG. In naked appearance, the Hydatiform mole looks like this, and the mass filling the uterus is made of the multiple chain and cluster of cysts of varying sizes. There is no trace of embryo, as we can see. There is no trace of embryo or the amniotic sac, and if the hemorrhage occurs, then that occurs in decidual space. This is a picture of complete Hydatiform mole. We can see the marked distension of the uterus by the enlarged vesicular chorionic villi. The adnexa, ovaries and fallopian tubes are visible on left and right side of the uterus. You can see the markedly distended uterus by enlarged chorionic villi. And on microscopic appearance, the basic finding are there are marked proliferation of the syncytial and cytotrophoblastic epithelium, proliferation of syncytotrophial and cytotrophoblastic epithelium, marked thinning of the stromal tissue due to hydrophic degeneration, and there is absence of blood vessel in the villi, which seems primary rather than pressure atrophy. And the villus pattern is distinctly maintained. You can see the complete Hydatiform mole demonstrating marked villus enlargement. There is villus enlargement, edema and circumferential trophoblast proliferation. And changes are also seen in the ovaries. There is bilateral lutein cyst are present in around 50%. These are due to excessive production of chorionic gonadotropin. They are also observed in multiple pregnancy. And bilateral lutein cyst, and these regress spontaneously within 2 months after expulsion of the mole. Their contained fluid is rich in chorionic gonadotropin, and it also contains estrogen and progesterone. Now we will talk about clinical feature of the Hydatiform mole. Talking about the patient particulars, it is prevalence among the teenage and the elderly patient with high parity. The patient gives history of amenorrhea for 8 to 12 weeks with initial features suggestive of normal pregnancy, but subsequently it present with the various other following manifestations like there is vaginal bleeding. The vaginal bleeding is most common presentation seen in 90% of the people, and often the symptoms mimic an incomplete or threatened abortion. The blood may be mixed with gelatinous fluid from the ruptured cyst, giving the appearance of discharge known as white current in red currant juice. Why this is called so? I will repeat again. The blood is mixed. The blood may be mixed with gelatinous fluid from the ruptured cyst. So blood is red and it is mixed with white colored fluid from the cyst. So white currant in red currant juice. And there is varying degree of lower abdominal pain may be there due to various reasons like overstretching of uterus, concealed hemorrhage, and rarely the perforation of uterus by the invasive mole, infection or uterine contraction to spill out the content. And there the patient may become sick without any apparent reason. There might be constitutional symptom, and there may be vomiting of the pregnancy become excessive to the stage of hyperemesis gravidarum. In 15% of the cases, it is probably related to excess of the chorionic gonadotropin. There can be breathlessness due to the pulmonary embolization of the trophoblastic cell in our 2% of the cases, and there might be thyrotoxic feature of the tremor or tachycardia are present on occasion 2%. It is probably due to increased chorionic gonadotropin. Note that beta HCG has the similar structural similarity to the thyroid stimulating hormones. That's why there might be expulsion of the grape-like vesicle per vaginum, and it is diagnostic of vesicular mole. Actually, in approximately 50% of the cases, the mole is not suspected until it is expelled in part or whole. So expulsion of grape-like vesicle per vaginum, and there might be there is history. The history of quickening is absent. And this is a picture showing the expulsion of grape-like vesicle from the vagina. And now talking about the sign, the early pregnancy feature, the signs, the features suggestive of early month of pregnancy are evident. The patient looks more ill than the accounted for. There is pallor is present and it is unusually out of proportion to the visible blood loss. This may be due to the concealed hemorrhage. It is probably due to iron deficiency, but may be megaloplastic due to folic acid deficiency also. And the feature of preeclampsia like hypertension, edema, and with or without proteinuria are present in about 50% of the cases. On rare occasion, the convulsion may occur. This may be rarely. There can be eclampsia. And on examination, per abdominal examination, the size of the uterus is more than the period of gestation in around 70% of the cases due to distension of the uterus, and the size of the uterus is equal to the period of amenorrhea in 20% of the cases, and it is smaller than period of amenorrhea in 10% of the cases. The frequent finding of the undue enlargement of the uterus is due to exuberant growth of the vesicle and the concealed hemorrhage. Due to growth of the vesicle and the hemorrhage, there is undue enlargement of the uterus. And the feel of the uterus is form elastic or Duffy feel. This is due to absence of amniotic fluid sac, and the fetal parts is not felt, nor any fetal movement. Their external ballotment cannot be excited, and there is no fetal ultrasound. It cannot be treated even by the Doppler effect of cardioscope. The negative abdominal sign are of value when this sign should have been present depending on the size of the uterus present in the particular case. Now talking about paravaginal examination, the internal ballotment it cannot be elicited. There is unilateral or bilateral enlargement of the theca lutein cyst of the ovary, as you have already seen in the picture. It may be palpable in 25 to 50% of the cases. The enlarged ovary may not be palpable due to the enlarged uterus. The finding of vesicle in the vaginal discharge is the pathognomonic of the hydatiform mole, as we have said already. And if the cervical os is open, the instead of the membranes, blood clot or the vesicle may be felt. Now, what is the investigation we can do? First of all, we should do the full blood count, ABO and RH grouping. This is almost common for abortion and even the ectopic pregnancy. Almost every case of the hemorrhage in early pregnancy, and the serum beta HCG level should be checked, and the coagulation profile. The hepatic, renal, and thyroid function tests are to be carried out. Liver function test, kidney function test, and thyroid function test. And the sonography, the complete mole appears as an echogenic mass with many anechoic cystic space. So we will see the picture. As we can see here, the complete mole appears as an echogenic mass with many anechoic cystic space. This is neither the fetus nor the amniotic sac. Fetus is present in partial mole but not in complete mole. The characteristic feature of the molar pregnancy is snowstorm appearance, and the this is, we can see the picture. It is seen in the USC in the complete hydatiform mole. Enlarged uterus showing hyperechoic mass with multiple cystic areas. After that, we have to do the quantitative estimation of the chorionic gonadotropin. The high HCG titer in the urine positive pregnancy test diluted up to 1 in 200 to 1 in 500 beyond 100 days of gestation is very suggestive, and rapidly increasing value of serum HCG level more than 1 lakh milli international unit per ml is usual with the molar pregnancies. The normal pregnancy value reaches a peak at about 10 to 14 weeks, and rarely it is more than 1 lakh, but it is more than 1 lakh in molar pregnancy. So the serum HCG value more than 2 multiple of median for corresponding gestational age is of value. So we can do chest radiograph should also be carried out to routine for evidence of pulmonary embolization even in the benign mole. The CT and MRI, the routine use of these are not recommended. We will not do the routinely form. And the definitive diagnosis is made by histological examination of the product of conception. And we can see the hydatiform mole showing the hydropic degeneration of the villus stroma in the histopathology. And what are the differential diagnoses of the hydatiform mole? The one is threatened abortion, next is fibroid or ovarian tumor with pregnancy, and next is multiple pregnancy. The twin pregnancy with one normal fetus and placenta, and the other with complete mole is differentiated from partial mole by cytogenetic and high resolution HSC studies. Now we will see the complication of molar pregnancy. The immediate complication are one is hemorrhage and shock. The causes of hemorrhage are the separation of vesicle from the attachment of residua. The hemorrhage may be concealed or revealed. The massive intraperitoneal hemorrhage, which can be the first feature of perforating mole, and during evacuation of the mole due to atonic uterus or uterine injury. So what are the 3 causes of hemorrhage and shock? One is the separation of vesicle from attachment to residua. Second is massive intraperitoneal hemorrhage, and thirdly the during evacuation of mole due to uterine injury or atony. Now we can the hemorrhage might cause shock. And on sepsis, there is increased risk of sepsis due to the as there is no protective membranes, the vaginal organism can creep up into the uterine cavity, and also due to the presence of degenerated vesicles, slobbing residua, and old blood. These all favors nidation of the bacterial growth. And also for third reason is increased operative interference. The 3 causes of sepsis are no protective membrane, so normal vaginal organism can creep up into the uterine cavity. Second, presence of degenerated vesicle that are suitable for growth of microorganism, and thirdly the operative interference, iatrogenic. And then next complication is perforation of uterus. The uterus may be injured due to the perforating mole, which may produce massive intraperitoneal hemorrhage. And during the vaginal evacuation, especially by conventional dilatation and evacuation method, or during curettage following suction evacuation. And the preeclampsia with convulsion on rare cases. And the acute pulmonary insufficiency due to pulmonary embolization of trophoblastic cell with or without stroma. The symptoms usually begins within 4 to 6 hours following evacuation. And the coagulation failure due to pulmonary embolization or trophoblastic cell, as they cause fibrin and platelet deposition within the vascular tree. So that was all. And in the late case, the development of choriocarcinoma following hydatiform mole ranges between 2 to 10%. The non-risk factors are recorded. There are various risk factors for conversion to the choriocarcinoma. Various risk factor for the malignant change can be remembered by the mnemonic HOT as HOTS. H stands for HCG, serum HCG level more than 1 lakh milli international unit per ml, more than 1 lakh HCG level. As for that, and O for patient, older patient more than 40 years, older patient more than 40 years, irrespective of parity, and also the younger patient less than 20 years, adolescent or old elderly. And next T for theca lutein cyst, that is large theca cyst more than 6 cm in diameter. And for an HOT, yes, what is the S stands for? Again, the S stands for the uterine size more than 20 weeks. If the uterine size is of more than 20 weeks, then that is that might lead to that is the risk factor. So that was all. Now we will talk about one of the important topic part, that is management of the Hydatiform mole. With the use of ultrasonography and sensitive HCG testing, diagnosis made entirely made early in the majority of cases, and the women may present with feature of severe anemia, preeclampsia, hyperthyroidism, or hyperemesis gravidarum. The principle of the management are suction evacuation of the uterus as early as diagnosis made, supportive therapy like anemia correction, other medical complication and infection correction, and counseling for regular follow-up. And the patient are grouped into group A and group B. The group A is in the group A patient, the mole is in the process of expulsion, and this is less common. And in group B, the uterus remain inert. Early diagnosis with sonography. So this is the flowchart from the DC Dutta's obstetric, showing the management of the Hydatiform mole, and we will see this. And the first of all, the management we have, as we have discussed, the patient are divided into two groups in the process of expulsion and uterus inert. In it, there is some supportive therapy like IV infusion, blood transfusion for the correction of anemia, and to correct anemia by blood transfusion to keep blood during the evacuation. And this is supportive treatment. In the process of expulsion, if there is in the patient with process of expulsion, the expulting mole, we have to accelerate the evacuation by suction evacuation with giving oxytocin drip. There should be gentle curettage following the evacuation in the selected cases only. And finally, we have to give the follow up the patient as a routine for at least 1 year, and the monitor maternal serum and uterine HCG and HCG level petrus or irrigation and exclude new pregnancy. So this is all. And if the uterus is inert, we have to do all this supportive therapy. And if the patient is young and desirous of child, we have different management. We have to do evacuation. We can do the vaginal evacuation, that is preferred. The cervix, if cervix is favorable, we have to do suction evacuation plus oxytocin drip and curettage in selected cases only. If cervix is unfavorable, we have to do slow dilatation of the cervix with laminating or prostaglandin E1, and suction evacuation with or without oxytocin, and curettage in selected cases. And we have to do prophylactic cytotoxic therapy, and this is controversial. And the follow-up, we have to do follow-up as usual, monitor HCG level and monthly follow-up and all this thing. And finally we have to evaluate for persistent trophoblastic disease. And if the patient rarely we have to do abdominal hysterectomy if the cervix is unfavorable and if there is bleeding per vaginal, and rest of thing is same. And in the patient greater than 35 years, family completed perforating asthma, we have to do hysterectomy, selective hysterectomy, and the prophylactic, these all are same follow-up and all this thing. So talking about follow-up part, after the definitive treatment, we have to do the follow-up part. The routine follow-up is mandatory for all cases for at least 6 months, The occurrence of choriocarcinoma is mostly confined to this period. So the prime objective is to diagnose persistent trophoblastic disease that is considered as malignant. And however, HCG level following evacuation should regress to normal within 3 months of the time. Initially, the checkup should be done at an interval of 1 week till the serum HCG level becomes negative. This usually happens by 4 to 8 weeks. Once negative within 56 days, the patient is followed up every 1 month interval for 6 months. The patient must not become pregnant during the period of follow-up. And post-evacuation follow-up protocol like history and examination, HCG assay, and in each visit we have to inquire about the relevant symptom like irregular vaginal bleeding and persistent cough, breathlessness, hemoptysis. We have to do abdominal-vaginal examination in each follow-up, the involution of uterus, ovarian size, malignant depositive fanny, and in the anterior vaginal, the luteins usually regress within 2 months. The detection of serum beta HCG are done in every visit, and in around 80% of patients, it undergo spontaneous remission. The sensitive beta HCG assay can identify women that develop malignancy. And so, but some cases chemotherapy are to be done in cases of risk of malignancy in the patient with the risk of malignancy. The regime is methotrexate. And for the contraceptive advice, once the serum beta HCG level undetectable for another 6 months following initial negative result, the monitoring is discontinued and she is allowed to become pregnant. But the pregnancy is delayed at up to 1 year for the cases of gestational trophoblastic neoplasia and up to 2 years if there is metastasis. The use of contraception, IUCD, is contraindicated because of its association with irregular vaginal bleeding and it confuses with choriocarcinoma. The combined oral pill can be used after HCG value has become normal, and the burial method of the contraception can be used. The surgical sterilization is another alternative. And what is the unfavorable manifestation? Persistent ill health, irregular vaginal bleeding, and continuing amenorrhea, appearance of respiratory symptoms, subinvolution, appearance of secondary metastasis in vagina, chest radiograph showing positive finding of cannonball shadow, HCG titer remain elevated. So that's all. Finally, we will see the difference between complete mole and partial mole. In the complete mole, the embryo or fetus is absent, whereas in partial mole, the embryo or fetus is present. The hydrophic degeneration villi is pronounced and diffuse. It is variable and focal in partial mole. The trophoblast hyperplasia is diffuse in complete. It is focal in partial. Uterine size is more than that in complete mole in majority cases. It is less than that in partial mole. The theca lutein is common in here. It is uncommon in the partial mole. The karyotype is 46XX in 85% of the cases, and it is entirely paternal in origin. In the triploidy is there 69XXX or XXY, and diploidy in 10% cases. The trophoblast is marked atypia of trophoblast. Beta HCG is high, more than 50,000. It is less than 50,000. The medical complication is uncommon, but it is rare. Classic clinical symptom is common. It is rare. Amnion fetal erythrocytes are absent. It is often present. Risk of persistent GTN is 20%. It is less than 5. Immunostaining P57KIP2 immunostaining is negative in complete mole, whereas it is positive in partial mole. So we can remember that this is like P57KIP2 is absent in partial. P for P. It is positive in partial. P for PP. P57KIP2 is present in positive in partial. So that was all about and molar pregnancy. Thank you, and we will meet again in the next video on some other topic of obstetrics and gynecology. Thank you. Till then, thank you very much, and for your patience.